Hi, Stark Centeno, and thanks so much for joining us. Going to start today with an interesting topic. Can you diagnose CCI with a routine neck MRI? And as usual, then we'll go into Q&A, whether it's about this topic or anything else. This is an interesting one because I get this question all the time, or I see on Reddit subs or Facebook groups. A lot of patients just throw up a single image from a static neck MRI and expect that someone is able to divine craniocervical instability from that image. So I'd like to go into what a routine neck MRI can show when it comes to upper cervical instability, what it can't show, and basically the concept of it showing circumstantial evidence that there could be craniocervical instability. So again, if you're just joining us, welcome in. The focus here is on cervical MRI, routine cervical MRI, and craniocervical instability, what that can show, what that can't show. And then we'll get into Q&A, whether it's about this topic or really any other topic is just fine. So we'll give it a minute or two. I see there's some people joining, some questions coming in. Again, if you want to ask questions, just put that in the comment, no matter where you are, whether you're on Facebook or YouTube. And before we get started, again, just to introduce the topic, can you diagnose CCI with a routine neck MRI? Is what we'll be talking about this morning. So let's get into this topic here, and we'll get started. So can you diagnose CCI with a routine neck MRI? Now, first, what is a routine neck MRI? It's important to understand that this is, the traditional neck MRI. The patient lies face up in a tube, basically. This is sort of a routine 1.5 Tesla MRI here. You can see the person's got a little thing around their neck. That's a neck coil, and that kind of focuses magnetic energy around the neck. Now, one of the big problems here is that usually you only get axial cuts from C2 to T1, and that's where this is focused. And as you might imagine, craniocervical instability is usually above C2. So basically what that means is that we're not going to image the high upper cervical spine in a routine neck MRI. Now, we can see some of that on sagittal slices, but the biggest problem we also experience is that the slice thickness is too high, meaning that there's fewer images. Now, this helps the imaging center quite a bit because MRIs take a long time to do. So if you take, for instance, a slice thickness of 2 millimeters, which would be perfect for us to see what we need to see, and you increase it to 3 or 4 millimeters, then you reduce the amount of time it takes the MRI. You can get more patients through the scanner in a day, and you can increase your profit margin as an MRI scanner or a hospital. So we rarely see slice thickness that is good enough to really look at, for example, the upper cervical ligaments on a routine neck MRI. Again, in addition, we really don't have the axial cuts either because they're not going high enough. So craniocervical instability. Instability means that the vertebra move beyond established norms when the patient moves their neck. Hence, instability requires more movement to diagnose, or requires movement to diagnose, sorry about that. And a routine neck MRI has no movement. So again, very simple concept here that you need movement to be able to diagnose instability because it's a movement-based concept, right? For instance, when I bring my head down like this, the atlantodental interspace increases too much. Or when I go side to side, C1, C2 moves too much side to side. So we need movement in order to be able to get to this diagnosis. Hence, it would make sense that a routine neck MRI can't diagnose CCI. Now, what can we see in a routine neck MRI? We're going to get into that, and that's what I call circumstantial evidence of CCI. And these are structural changes that often happen because of craniocervical instability. So those routine changes are things that are fairly predictable in CCI. So we're going to go through those. So these are some of the common circumstantial structural changes that we can see due to CCI. We can see a facet effusion or swelling from C0, C1, 1, 2, 2, 3 facets. We can see facet osteoarthritis, which is usually hypertrophy. We can see a pannus. We'll get into that, swelling behind the dens at C2. We can see things like multifidus atrophy and rectus capitis posterior minor atrophy. So facet effusion, this just means swelling in the facet joint. So this is C0 here, C1, C2. Usually you see this on a sagittal or side view. That white bit back there is fluid in the C1, C2 facet joint. So that shouldn't be there. So that's swelling in that facet joint. If we go to this on the right, this is C0, C1, C2. Again, another sagittal view. This white stuff here is swelling in the 0-1 facet joint. This is swelling in the 1-2 facet joint. So normally we don't see swelling in these upper neck facet joints. And when we see it, it's usually due to excessive wear and tear. And that's going to be much more common in someone with craniocervical instability. Facet osteoarthritis is another one that we see quite a bit on routine cervical MRIs. It's pretty easy to see. So this is facet osteoarthritis here. So if we look at this joint, this is the joint here. So if we look at this joint, this is the joint here. And you can see that this joint is much bigger than that. So again, normal C2-3 facet joint size, a little bit big, but maybe mild arthritis. And this one much, much, much bigger. So that indicates facet arthritis. Over on the right here, a little more subtle signs of facet arthritis, but where the joint isn't quite as big. So this is the normal joint. This is the arthritic joint. On the arthritic joint, you can see swelling within the bone that's happening here. You can see some bone spurs forming, etc. So facet osteoarthritis in the high upper cervical facets, 0-1, 1-2, 2-3, can certainly indicate that there is wear and tear, excessive wear and tear happening at that site. Pannus, this is going to be swelling behind the dens. So you can see here, this is the dens of C2 on a sagittal, and you can see this dark area back here. The bone is here, but there's something else between the bone and the back of the spinal canal, and that's a pannus or a swollen bursa behind the dens at C2. Same thing here. This is the dens. We can see a very small pannus behind the dens at C2. The issue here is that can put some additional pressure on the upper spinal cord and medulla. Multifidus atrophy is another thing that we can see. Multifidus atrophy, what does that mean? So these are the segmental muscles that help to stabilize the head on the neck at C2-3 here. And this dark equals muscle, but anytime you see white in here, it means no muscle. So as you can see, if this defines this compartment here, right? If you look at the amount of white versus dark, and dark is muscle, you can see that these muscles are severely atrophied. This little wisp of dark here used to fill this whole compartment. This little whisk of dark here used to fill this whole compartment. So we're seeing here on the left here about 80% atrophy of that muscle. So think about that for a second. If I were to put a cast on your leg and 3 months later we take the cast off and your thigh muscle has decreased in size by 80%, you wouldn't be able to walk. It would be months before you were able to walk. Normally, maybe if you worked on it really, really hard, you might be able to get it back over 6 months to a year. But that's the kind of thing we're seeing here. Now, same thing here. This compartment that I'm outlining here should have all dark. All dark equals muscle. The white is no muscle. So you can see here, this is about a 50% atrophy of that C2-3 muscle. Now, this is a common finding in patients that have headaches coming from their neck. And the kind of findings I'm showing you, we'll go through them real quick. Again, it's important to note that many times this is not read out on the MRI report, and these sorts of things aren't. Rectus capitis posterior minor atrophy. This is the rectus capitis posterior minor back here. This is the rectus capitis posterior minor back there. So again, here and here, it goes from this dark area that goes from the skull all the way down to the back of C1. And as you can see, it's not fully filling this space. All of this in here should be dark if that was a normal rectus capitis posterior minor. Now, why is this important? Because this is the muscle that opens the gateway, if you will, for the cerebrospinal fluid to flow towards the back of the brain. So if we want normal CSF flow back here as we move around and do things, that muscle has to be normal because it opens this area right here for CSF flow. So going through this, and I'm going to go backwards for a second and then go forwards. Going backwards, this one is not going to be in your MRI report. This one is not going to be in your MRI report. This one may be in your MRI report if it's large enough, but it's only if it's pretty large. So you got to realize that these are not things you're going to find on your MRI report, and most clinicians don't read these MRIs themselves. They only look at the MRI report that is handed to them. So these things will be invisible to your doctor unless your doctor knows how to read the actual images. This one will be on your MRI report. Most of the time, I would say they'll call facet hypertrophy, which means arthritis in the facet. This one usually won't be on your MRI report unless there's a lot of fluid in these joints, because radiologists don't really understand, if they don't look at this area all day, how much fluid should be in these joints. They just don't look at this area all day, every day. So again, of these, this one is probably not going to be on your MRI report. This one is probably going to be on your MRI report. This one will only be on your MRI report if it's pretty big. This one will definitely not be on your MRI report, nor will this one. So important to realize that most of these things are not going to be on your MRI report. So in conclusion, you need movement-based imaging like DMX or upright MRI with flexion extension to diagnose CCI. However, you can find circumstantial evidence of CCI in a routine neck MRI. So do me a favor, take a second here and like this video, because we want this content to get out to more patients. If you are conscious of the fact that there are other CCI sufferers like you out there who are just not getting exposed to good information, please take a second and like this video wherever you are, whether you're on Facebook or YouTube, because that helps us get this out to more patients. So it's a way to pay it forward in the CCI community for other people that suffer with this problem. Okay, so I think we can go to questions, although before we go to questions again, let me see here. So just want to put a plug in again before we go to questions. If you're not on the Reddit sub, PICL, please join that sub. It's got 270 members now. This is the page where I answer patient questions. I do it 7 days a week and probably check it 10 times a day. So as you can see, tons and tons of questions and answers here, questions and answers, questions and answers. It just goes on and on and on and on and on, hundreds at this point of patient questions that I have formally answered. You can also search up here and just let's say you're interested in looking about things concerning Chiari. So we just typed in Chiari there, and all of my Reddit questions about Chiari are going to come up. So if you're out there at 3 a.m. saying, God, I wonder if Centeno has answered questions about Chiari, you can find that out. I wonder what to do if I've got a question about NSAIDs, like ibuprofen. Boom, got three threads right there to read. Or I wonder what Centeno thinks about steroids. Boom, it's right there. Or I wonder what Centeno thinks about the specific medication Nurtec. Boom, right there. So it's all here. It's growing leaps and bounds, and I'd recommend that you join it. Join it if you've got CCI, because lots of patients just ask general CCI patients. Join it if you're thinking about getting a PICL, because we have a lot of that as well. And join it if you're going to get a PICL or you've already gotten one, because again, you can ask questions here. And every time you ask a question here, it helps the entire community of CCI patients, because everyone gets to learn, just like these Facebook Lives. Okay, Andrea, is rotation in DMX or DMX-like imaging important if you have AARD in addition to CCI and AAI? AARD, lateral-axial rotational deformity. I don't know what AARD means. That wouldn't be a standard medical definition for anything. So you'll have to give me more information about what AARD means there. That's not a standard US medical abbreviation. Asthma, can the occipital nerves be irritated even without instability? Absolutely. You can get tightness in the suboccipital muscles. You can get postural changes that can also irritate the occipital nerves. Asthma. What is the biomechanical cause of the feeling of something being out of place and of compression at the base of the skull? It's just abnormal loading on the joint, right? We're not used to feeling areas in our joints that have abnormal loading. And when we get that, our body throws in some pain sensation or some sensation that's abnormal so that we stop doing whatever is causing that. Because if you continue to abnormally load any joint, you'll cause arthritis in the joint. So your body is triggered to do that no matter where it is, whether it's in the upper neck joints or whether it's in your knee or ankle joint. Andrea, putting one's arms in front and extending them forward against the wall, putting one's arms in front and extending them forward, maybe while you're against the wall, produces compression-like symptoms in the right arm. Medial ulnars, neck issue, compression occur at lower levels. If I understand your question correctly, usually what happens in that case, so I think what you're saying is you have your back against the wall, you're putting your arms out front like this, and you're starting to get some numbness or tingling down arm. Normally that's due to thoracic outlet syndrome and or issues in the scalenes. Now that could be secondary to craniocervical instability, could be secondary to lower cervical radiculopathy or lower cervical disc bulges. It could be caused by a lot of things. AT, hi doc, for dry needling, what's an ideal frequency you prefer? Once a week? Should the focus be just dysfunctional right side or okay to target other tight areas of the body? Yeah, so dry needling once a week is just fine. I wouldn't recommend you do it any more than that, simply because you don't want to do a lot of damage to the area that it can't recover from by the time you get the next treatment. And then yes, dry needling can help with muscle recruitment, so you definitely want to be strengthening as much as you can during that time. Again, let me put out a call here to make sure that you like and share this video. Again, if you found this video, for every one of you that has found it and is getting your questions answered here, there's 100 or 1,000 CCI patients that haven't found it because of the algorithm. So if you can like the video, that will help other CCI patients like you find it. Kasian, What percentage of people don't need lysate to treat nerves with hydrodissection? They tolerate PRP for nerves just fine. I think PRP, if it's leukocyte poor around nerves, is probably okay. It tends to cause more inflammation, but I think it's probably fine. It's just when you get to leukocyte-rich PRP, meaning red PRP, then that can be a potential problem around nerves. So leukocyte-poor PRP, which would be amber in color, is usually fine around nerves. The only difference with platelet lysate is platelet lysate tends to be more anti-inflammatory than platelet-rich plasma. Lisa, thank you for really explaining CCI for family and friends. I also sent it to an employer. Lisa, happy to do that. I'm not sure if you guys know about that or all of you know about that. I got asked by a couple of patients in a row about going to and basically creating a video for CCI patient families. So my goal here was to create a video for families and friends, or family and friends, so that family and friends and CCI patients could understand what CCI patients go through. As you know, this is a hard thing to get diagnosed. It's a hard thing to take just physically. It does a number on the body. And a lot of family and friends don't understand it. So I did this video specifically with that in mind to share with family and friends. So I would really encourage you to go to my channel here and download the video and share it with your family and friends, because it was meant for them. It was meant to try to explain to them what you're going through, that this is a difficult problem to diagnose. It can be a difficult problem to treat, that you need to find subspecialty care to be able to diagnose and treat it. So yes, Lisa, I was happy to do that. My hope is that it helps some of you explain this to your family and friends and reduces some of that friction that can occur with problems like this. AT for hydrodissection with PICL, would you prefer me to get that treated every 6 weeks? If not responsive, or wait until 4 to 6 months of ligament healing, that treatment with another PICL if needed. I'm not quite sure what we're talking about being hydrodissected here. Maybe the occipital nerve, that could be. AT, if you're going to treat the occipital nerve with platelet lysate or PRP hydrodissection, you would want to make sure that it's a rectus capitis posterior major plane block. That way you can also get the suboccipital nerve treated at the same time as the greater occipital nerve. So if that's what you're talking about, that's going to be fairly specialized. And I don't know how many clinics out there will do it that way. Normally, when you're doing a greater occipital nerve treatment, you're getting it right as it comes out near the upper trapezius, much higher up, but then you won't be able to treat the suboccipital nerve at the same time. The reason for treating the suboccipital nerve is that rectus capitis posterior minor atrophy that happens because of that suboccipital nerve. Mustafa, is Chiari-0 necessarily caused by instability? What causes Chiari? Chiari-0 is not necessarily caused by instability. It's usually something that you're born with. And by itself, it doesn't cause any problems. It's Chiari plus something else that causes the issue. So Chiari plus atrophy of that rectus capitis posterior minor. Chiari plus a shallow C0 C1 joint, for example. Without the plus, Chiari-0 doesn't do anything in the vast majority of people that have it, meaning there's lots of people walking around out there with Chiari-0. So realize that Chiari by itself, meaning Chiari-0 or CTE, is not symptomatic. It takes something else to make it symptomatic, but you're generally born with it. Christy, how do we get insurance to cover the DMX? There's a process that needs to happen to convince them. Yeah, Christy, I don't know if you'll get insurance to cover DMX. I've really never tried to do that. You could certainly give it a shot, but I don't think that it's something that's likely to occur. It would be technically video fluoroscopy, and that's paid by certain time units. But I would imagine that most DMX centers aren't set up to bill for that, nor are they probably in network for that. So not quite sure what to tell you there. I don't think I've ever seen it covered by insurance other than that be standard health insurance, other than maybe workers' comp would pay for it, or auto accident insurance, that kind of stuff. Mustafa, can you have flat condyles and mild Chiari but no instability? Yeah, you can have flat condyles and no instability for sure. You can have mild Chiari with no instability. What is the pain caused by in this case? It could just be atrophy of that rectus capitis posterior minor, which I talk about in, well, actually that's not all my videos. That's just the ones it's finding for me, which I talk about in this video here. Chiari research breakthrough may change treatment. So I would watch that video if you get a chance, because that'll explain all of that. Lori, I thought I saw a list of what imaging you need to diagnose CCI. I can't seem to find it or imagined it. A list would be very helpful. I think you're talking about a YouTube short I did. And I'll have to find it myself here. Let's see if I can search it. Got too many. Yeah, so which imaging measurements, video, but I think you're talking about this one. What kind of imaging do you need to diagnose CCI? So that's this video here. So that goes through that in a very short, compressed format. So if you go to my channel and you search the channel and just search under CCI imaging, you'll be able to find that, and it goes through it pretty succinctly. Can we have instability due to atrophied muscles, but without the ligaments being damaged? How can we see muscle instability on image? Will the measurements be normal? Yeah, so Mustafa, it's a good question. There are two different kinds of instability. There's muscular instability and there's ligament instability. Muscles help within the mid-range, meaning that if you've got a range of motion of a joint, in the middle part of that range of motion, the muscles are active to provide stability. If you push the range of motion of the joint to its very end, so think about your fingers, right? If we take a finger and we push it all the way back, eventually it stops. And it stops because the ligaments are not permitting those joints to go any further. Now, if these ligaments were unstable, then we'd get those joints to move further. And so that's why the imaging that we do is to set up to look at that phenomenon, meaning the second ligament phenomenon. Because we can say this finger joint shouldn't move a certain amount or degrees beyond neutral here. If it does, then it's unstable and the ligament is damaged. What we have less of is mid-range imaging. Now, I think with AI, we're going to see that here probably the next 5 or 10 years. It's not rocket science. I think the average AI system could be set up to do it now, but there isn't. It's like anything else. It has to be a commercially available product that someone wants to buy. So I think we'll see muscular mid-range imaging come in, where they're probably looking at things like the acceleration or velocity of motion being too high. And we can see that on DMX. We call it now sloppy movement, where it seems like the patient has no control. But again, I think to quantify it, we're probably going to need AI-based systems. Mustafa, what's the difference in symptoms between muscle instability? I think I got that one already. Christine Huff, I need help. Gotcha, Christine. Just if you have questions you want to answer, just put them on down there. I'm happy to answer them. Ben, do you look at all these details in a teleconsultation where we send our imaging over? Yes, all of those things are looked for. I mean, I think what we talked about today, yes, all of those things are looked for in a teleconsultation when you're sending the imaging over. So realize that in that process, the first thing I do is a pre-screening. In the pre-screening, my job is to try to see whether or not I have enough information to get to a decision on that person. And I do that because I don't want you spending money on a telehealth consultation with me if I'm not going to be able to tell you anything meaningful. And so if not, then we recommend you get some more imaging before the telehealth. If you do have enough information, then I'll green light the telehealth, and we'll get into all of those different things during the telehealth. Devayan, as I'm from India, DMX is not available. I've already sent the x-ray pictures. It's with ISIS. I'm still waiting for telemed appointment. Kindly check my x-rays. Yeah, Devayan, I checked that this weekend on Friday and Saturday. I didn't see your email come through to me. Now, if you send it to ISIS, that's a different story. ISIS is in a different location, and I was traveling. So if you want to send it to my direct email address in a downloadable format, meaning you've got to be able to upload it to an image sharing site or a file sharing site like G Drive, Box, Dropbox, and then I'm happy to download it on my end and take a look. But I didn't see your images in there in the files that we had. So I asked ISIS to go and see if she can find it, or obviously when I'm in the office tomorrow, I can try to find it. Edgar, where can we find a DMX or rotational imaging clinic for CCI or upper cervical instability? DMX, we've got a list of DMX places. So if you reach out to ISIS, she can get you that. ISIS's email. Hold on a second here. I'm just going to pull up ISIS's email for you. Okay, I'm going to put that in the comments, and it should show up in your comments wherever you are. You can get in touch with her. She can give you a list of DMX places. If you don't have a DMX near you, then you can also use this video. Where did it go? Right here. You can also use this video right here. So replacing DMX, how to use X-ray DDR. So if you were just to go to my YouTube channel and you just search DMX, that should come up, comes up right here. And it's a video to teach an imaging center how to use X-ray to get the similar views to DMX. So either one would be fine. Obviously, DMX is preferred. If you can't get DMX where you are, then you can also do it that way with regular X-ray. Oli Khan, we know that brain injury and CCI symptoms are so close. So without DMX, how can we be certain it's CCI? Yeah, Oli, it's a good question. I think I've got a couple videos on that for short answer. Let's see here. That didn't work. I got too many videos, Oli. Maybe it's coming out. Anyway, long story short is, I think when it comes to whether it's a concussion, brain injury, or CCI, there's a couple of simple things you can do, right? The first simple thing you can do is what I call a collar test. So that means get a cervical collar, cheap one off of Amazon that's comfortable, wear it for a couple of hours and see if it reduces symptoms. If you have a brain injury, that won't help. If you've got an issue coming from your neck, that may help. Another thing would be to tie your symptoms to neck movement. And then finally, a hands-on physical exam can show an experienced provider like myself that it's probably coming from your upper neck. And then, yes, there is imaging as well. There's DMX, upright MRI with flexion, extension, etc. But realize at the end of the day, it's pretty common if you had something hit you hard enough to cause a concussion or brain injury that your upper neck gets injured. And I got to say, I see some of the subs out there on post-concussion syndrome, and I have to say I'm shaking my head because I'm seeing all of these people who probably have simple upper cervical injuries that are easy to fix. But by not getting it diagnosed and just letting it sit there for years and years and years, these are becoming much harder to fix. So if you're on some of those concussion subs and threads, please educate people that you have to get your neck fixed. And it's not just going to see the neurologist. That's probably not going to get diagnosed at the neurologist because that's not what neurologists do. Or it's not just going to the physical therapist or the vestibular place, because again, it's not what they do. Many of those patients I see who are miserable just need to get their upper neck facet joints, for example, injected with some PRP by someone who knows how to do that safely. So, please spread the word, because I have to say, I read those subs and I'm like, God, there's hundreds of people on here who are miserable, who all they really need to do is to treat their upper neck. But treating their upper neck beyond conservative care and not with a fusion. Ben, is it possible for muscle atrophy in the neck to be reversed? Good question, Ben. I don't think anyone knows that for sure. I think there's one study out there that shows that it may be possible. That study is by Jim Elliott. But I think the jury's still out on that. My sense, it is probably possible. Carol, submit advance by Harry. If we can get to Colorado for treatment, does your office have a list of hotels near your office? We do. There's a list of hotels that we provide. There's a bunch that are near our office. Everything from fancier ones to mid-tier ones to cheaper ones. So yes, we have a whole list, and usually some deal with the hotel as well. Asthma, if you have flat condyles and KRE0, gentle manipulations via an osteopathic chiropractor are not recommended. You would really want to do low velocity upper cervical work. Again, low velocity upper cervical work. So what that means is things like AO, NUCA, orthospinology, Blair, that are low velocity, low pressure techniques to try to get the bones back aligned, but not the standard turn the head type of adjustment. So very important to understand that. Christy, how does treating the vagus nerve affect recovery? Doesn't really seem to move the needle as far as I've seen. I think I had one patient that may have reacted with a flare-up for a week or two related to that I could pin to that. Outside of that, it doesn't seem to move the needle. And that person had primary vagus issues. So I think their vagus nerve was very, very sensitive, meaning that was 98% of what was wrong with that person. They didn't have headaches or the other types of things that we normally see with CCI. John, can you treat costochondritis same time as PICL? I feel like I developed it from bulge at 6-7. Yes, we can treat rib issues, costochondritis, whether it's costochondritis or something else. But we treat the ribs and thoracic spine all the time in our CCI patients. Rachel, that's amazing. It's so hard to describe to people, especially when you look perfectly normal on the outside, but having a neurological breakdown on the inside. Very thoughtful for you to make a video to help our loved ones understand. Yeah, just if you're just joining us now, what Rachel's talking about here is this video I just made. It just goes into a message for family members, right? It talks about how difficult this problem can be on somebody. It talks about how hard it can be to diagnose. The goal there, I had several patients reach out to me, 2 or 3 in a row, that said, hey, can you make a video for family members? I'm trying to explain this to my family, and they're having a hard time wrapping their head around it. Or I'm trying to explain this to my best friend, and he or she is having a hard time wrapping their head around it. So I did that video, and please download it, share it, whatever, with and get it to your family members so they can understand what's going on with you. That's very important to me because, when patients have family member support, it makes it much easier for them to recover. Again, no matter where you are, if you're just joining us, please like the video, because if you get your questions answered live by a physician expert in this space, for every one of you getting your questions answered today, there's 10 or 100 out there who can't get access to this because they'll never find it. And the only way to help them find it and to pay it forward in the CCI community, just like that video I did for family members, is to like this video where you are. Stephanie, 3 months out from PICL number 2. Is it okay for me to get MLS therapy? MLS stands for multi-wave lock system laser therapy. Yeah, that's just fine, Stephanie. Not a problem. Ben, if jaw is misaligned due to CCI or atlas misalignment, will this need to be treated as well? Yeah, so Ben, we treat the jaw all the time in our patients. So that's a pretty common thing for us to do. And realize, as I always discuss in these Facebook Lives, is that, when you don't have intrinsic stability in the upper cervical spine, many times the jaw and this anterior neck strap muscle system takes over and tries to be a primary stabilizer. And it's not designed for that. So the jaw starts to complain. And then given enough time, the jaw starts to develop problems of its own. So it's frequent for us to treat the jaw when we're treating the upper neck. Edgar, injured a few cervical discs, C4 through 7, 2 herniations and 1 bulge. 7 months ago, still having issues specifically when bending forward. Yeah, Edgar, so those are all things we treat non-surgically. Usually those are platelet-based treatments with precise fluoroscopy and contrast confirmation type imaging guidance. So those are, I would encourage you to reach out to the Centeno Schultz website. So if you just go here, centenoschultz.com, you can go and obviously book a telemedicine appointment to have someone evaluate that. John, can you inject the dorsal scapular nerve? Do you inject 5/6 up with that dorsal scapular nerve for rhombo weakness? Yeah, John, we first start to treat the issues in your neck, and usually then that goes away. Now, we can treat the dorsal scapular nerve if it's required, but usually it's not required. Edgar, doctor injected my neck during sports. Don't know what that one means, Edgar. So maybe if you could put a little more information there, that would help. Hold on a second, guys. I apologize. I see one of my dogs has gotten out. I got to tell my wife about it. So I'll be right back. Code is out. Yeah. Okay, sorry about that. We have very large Alaskan Malamutes who don't normally play nice with other dogs, so needed to get him inside. AT for hydrodissection. I was talking about specifically treating the suboccipital nerve, supplying the. Yeah, so that has to be done at the rectus capitis posterior major plane or obliquus plane in order for that to work. So that's not the traditional hydrodissection technique that's usually done at most places. That's a different one I was describing. So yeah, you would want to probably come to us to do it, or we'd have to try to explain to someone how to do it because it's not the usual type of hydrodissection for occipital neuralgia. AT, thanks, Dr. You're still connected to any expert you mentioned before. I didn't know how to spell his name and try to reach out myself. Ado Zylstra, yeah. Yeah, I don't know where Ado is here. That is a hard one. Let's see where Ado is. Oh, I guess he is still practicing. So this is the guy at Connecticut. Haven't seen him in years. He was looking good. Adel Zalstra is one of the physical therapists we trained many, many years ago to do trigger point dry needling. So he was really the first physical therapist, one of the first physical therapists on earth to do trigger point dry needling. And he formed a company to educate others to do it. And so I'd recommend reaching out to Ado to see if you can find a local dry needling specialist in your area. I think what we're talking about there is that trigger point dry needling of the suboccipitals can be very helpful. So that's something to consider as a conservative type treatment. Now, you don't need to spend a ton of money. You don't need to use neck weights with this. You just need to find a good physical therapist that knows how to do it, that feels comfortable doing it. And usually it's just an add-on to a physical therapy visit. So I think that was part of that discussion that we had maybe a number of weeks ago. John, is there any correlation between dorsoscapular nerve and costochondritis? One is flared, so the other not usually. There could be, meaning you could have dorsoscapular nerve issues causing problems in the scapular stabilizers that then causing too much wear and tear between the scapula and the ribs. But again, lots of other things cause that. So be a little careful there because you may go down a rabbit hole that bears no fruit because the medical provider doesn't know enough to know all the different things that cause irritated ribs, and they're only focusing on the one thing they understand. So be a little careful. Asthma, multifidus atrophy and RCP atrophy, not the same, different. Yep. Ben, is accessory nerve damage common with CCI? Would you expect to see muscle atrophy and traps in shoulders in this case? Can this be reversed? Not as common with CCI, although we've seen it. The accessory nerve goes on the outside of the sternocleidomastoid here on its way down to the upper trap. And so I have seen it a few times. We can treat it directly. It's very easy to treat when we are treating the CCI. Hannah, hey, Dr. C, when would a patient typically start seeing improvement? Dizziness from PICL. Yeah, Hannah, I think usually in that same 3 to 4 month time frame. Now, some patients might be earlier because their dizziness was primarily from C2-3, for example, and we treated C2-3. But if the dizziness is related to instability and then that irritating the joint, we've got to see things firm up as far as the instability is concerned. Lori, thank you. Happy to help. That's ISIS's email address if you're interested in doing a telemedicine. ISIS is your person for that. There it is on YouTube. So icabral@centenoschultz.com. I'm recording this, so if you don't catch that, you can go back and get it on Facebook or YouTube as well. Can trigeminal nerve be involved in difficulty raising right eyebrow? Not really eyebrow. So that's going to be probably more either the facial nerve or the supraorbital nerve here. So again, but realize, I think what you're bringing up is that this frontalis muscle links into a fascial plane that goes all the way back here and connects into the suboccipital muscles. So there is some linkage between the two that I've always wanted to explore. There's not much published on that, but it certainly makes sense that they are linked. Zarko, if moving neck aggressively in all directions doesn't aggravate symptoms, that makes CCI less likely cause of issues. It certainly adds weight to it not being CCI. We'd have to see the rest of the data, though. It's like anything else, right? You've got those scales. Yes, CCI, no CCI. And you put little weights on there. Imaging, history, physical exam, all of those tend to point one direction or the other. AT, lastly, just to 100% clarify, are you good with me? Try dry needling right now, 1.5 months out PICL, while attempting to thread the needle. Yeah, that sounds fine. Zach, C1-2 overhangs of 2.8 and 2.3 with neuropathies in random areas. I can bend my neck to either side without changing symptoms. Does this rule out overhang triggered by neuropathies? No, I don't know what you mean by neuropathy. Again, neuropathy has a very specific meaning to a doctor. It means nerve damage, and it could be to a particular nerve. Now, if what you mean is you've got nervy type symptoms, that's generally not neuropathy. That could be issues with the nerve, could be issues with the spinal cord, etc. So, there's 8 different kinds of CCI. You're talking about one type of the 8, one of 8, which is CCI type 2B, which is overhang. You could have any one of the other 7 types of CCI. I don't know. And if your question is 3 millimeters enough of instability? Yeah, it's 3 to 4 millimeters of overhang when we start to get concerned. And you have to put that in context of that person. So that means it's one piece of the puzzle. So another piece of the puzzle is history. Another piece of the puzzle is response to treatment. Another piece of the puzzle is eventually hands-on exam. Matt, what does bobblehead mean? It just means weakness in the neck, where you feel like one of those bobblehead dolls and you don't have good control of your head on your neck. Hannah, when would symptomatic facet joints start to heal the neck out? Yeah, Hannah, I think I answered that already. It depends on whether or not instability is driving that facet joint. If instability is not driving the facet joint, then usually a couple of weeks to maybe a month or 2. If instability is driving the facet joint problems, then we're talking about a longer term issue where you're going to have to reduce the instability. JS, what muscle causes eye twitching and how do you stop it? First trip to the PT was aggressive trying to lie my neck. Then he used a TEM machine. He told me it was from his manipulation, not TENS. Yeah, I mean, that could be due to frontalis. It could be one of the other eye muscles. If your question is, does it have a link to craniocervical instability? It could, although there's lots of other things that cause eye twitching. Christy, my chiropractor recognized it and sent me for a DMX life-changing moment. Let's see, Christy, I'm trying to remember what in particular we were talking about. I'm going backwards here to try to see that so I can answer better. Not sure there. Christine, my neck has completely collapsed. It is because my neck. Yeah, Christine, again, happy to answer any specific questions that you have. Edgar, I have 2 herniated discs with annular fissure, small bulge. Yeah, Edgar, so I, again, do telemedicine evaluation. So that's going to be scheduled here or with ISIS. And if, my practice these days tends to be laser focused on craniocervical instability. We have lots of doctors in our clinic that focus on general lower cervical issues. So if it looks like more craniocervical instability, then I would get involved. If it looks more like routine disc bulge issues in the neck, then one of those other doctors would probably get involved. Christine, because my neck muscles. Again, Christine, if you've got specific questions, happy to answer them. Matt, do we need to be clean shaven for the PICL? If you mean in here, that would really depend on what we're treating, right, Matt? So if we're trying to treat like a TMJ, then yes. Outside of that, having a beard probably isn't going to affect too much of what we're doing. It might slightly increase infection risk, meaning that we do sterilize around the mouth area, but I don't know how to quantify that, meaning I'm sure facial hair may have some impact on intraoral procedures. but probably not a big impact. So if you don't want to shave your beard, it's probably not going to move the needle very much. Ben, does damage to facet joints need to be significant to be seen on MRI if facet joints have sustained significant damage? Usually, if the damage is significant, we can see that on MRI. Oli Khan, is there any non-procedural treatment for CCI without physical therapy and chiropractor? Probably not, Oli. I mean, there's some home exercises that I've got. So if you go to my channel here, there is an entire set of rehab videos, here, all of these ones. And they start right here, and then they go through various ones. So that's something that you may want to take a look at on my YouTube channel. And if you just type in rehab on the search for my YouTube channel, so if you were to type in rehab here, you can get all the rehab videos to come up. Casey, do you adopt Travell and Simon worldview for tumor injections or use your pain maps to help diagnosing? Casey, I think trigger points can be very important. They can be gotten rid of through trigger point dry needling. And if you need trigger point dry needling, these days that's usually done at a physical therapist office who has experience in trigger point dry needling. We've also got a physical therapist that does trigger point dry needling. So we definitely believe in trigger points and getting rid of them, but not part of what I get directly involved in other than to recommend someone to get that done. Ben, last question for me. Are there any supplements or medications that we take in the meantime to help with symptoms? You know, Ben, I think classic anti-inflammatory supplements can be helpful. That would be fish oil, curcumin, MSM, glucosamine, those sorts of things. Medications are going to be very specific to what's happening to you, so I don't think I can make any specific recommendations there. Oli, why does taking a deep breath into my upper chest cause me to feel pressure in my chest? Blood flow changes my brain and black out in a few seconds. That one, Oli, you're going to have to get checked out by local doctors because lots of things could cause that. Hannah, by the way, Dr. C, thank you. Since my acceptable hydrosection, my severe headaches are gone. Well, thank you, Hannah, for that feedback. So I think what Hannah's describing is occipital nerve hydrodissection, meaning that we inject platelet growth factors around those nerves. Hannah would have gotten that rectus capitis posterior major approach that we were talking about, which also treats that suboccipital nerve, which then supplies things like the rectus capitis, posterior minor, and major. Got that. Thank you, Hannah, for that information. What is your Facebook page name? So if we go to Facebook, hold on a second. Facebook is being a little slow. So that's going to be Centeno Schultz Clinic right here. So it's Centeno Schultz Clinic. So Centeno Schultz Clinic is the Facebook page that I would use most often. I've got a personal Facebook page, which I usually use more for business than anything else. And then that would be Chris Centeno, MD. And then Regenix has a Facebook page as well. But the one I would use most often is the Centeno Schultz Clinic Facebook page. Casey, do you commonly see trigger points associated with CCI or other joint abnormalities? Yep, trigger points are trigger point problems are pretty common in CCI patients. Zarko, the last 4 months, I've started experiencing frequent myoclonus, mostly during night. Could that be in CCI or Chiari can cause that? Chiari less common, could be CCI, could be other things like a lower neck disc bulge or stenosis. So again, multiple things. Okay, guys, so we're coming up to the hour and my dogs are going crazy here. I think I got to go hike them. And so I want to thank you for spending the time today, asking all the great questions. Again, if you get a chance, join the PICL subreddit. So if you go to Reddit and type in PICL, this will come up. And we've got 270 members now, and I don't know how many questions. I mean, it just goes on and on and on and on. This is where I answer questions about general CCI issues You can see certain patients putting their MRIs up here. I answer questions about PICL procedure. I answer questions about other procedures. This is me speaking at the Vatican when I still had brown hair. That was interesting one. How has your faith informed your treatment philosophy? I spoke twice at the Vatican on stem cells. I relayed here a funny moment afterwards, because I had said during the lecture, and this person asked about that I grew up Catholic, and my mother always wanted one of her sons, she had 6 sons, to become a priest. Wasn't going to be me. So I said it was well received. The funniest moments when a Jesuit priest approached me after the presentation, yanked on his collar and said, "It's never too late." So lots going on here. I recommend that you join this because it's like what we're doing today, but in more formal back and forth in writing. So again, thanks so much for watching. Have a great day. If you get a chance and you haven't, like this video, because that's how other patients find it. If you want to pay it forward in the CCI community, like the video. And I will be here next week on a different topic, lecturing away on stuff and answering questions. So thank you.